Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Yep, and here we are once again. Welcome to the program. If you've not been with us before, you're in for a treat. We've been getting together. Dr. Juleff and I have been doing this for a long time, and we've talked about all kinds of conditions, the big picture, the small picture, and everything in between. And today you're going to see something that you hear on TV a little bit, and I thought it'd be sort of appropriate and sort of the doc, so to bring you a show about deep venous thrombosis. What's that all about? And we see him abbreviated on TV, Doc. Oh, yeah, he's got DVT. DVT, that's not good, is it?
Most of the time it's not,
yeah.
No.
Well, what is DVT? What is that?
Well, deep venous thrombosis has to do with abnormal clotting. You know, there's normal clotting and then there's abnormal clotting. I mean, we our blood clots for a reason, and sometimes it does it inappropriately, and it can create problems. But,
so there's good ones and there's bad ones.
Yeah. So deep venous thrombosis are blood clots that occur in the veins in our legs. And typically it's in the deep venous system. Mm-hmm. You know, there's two systems of veins in the legs, deep system and superficial venous system. And, you know, the superficial venous system is the kind of the system that we deal with and treat day in and day out.
Yeah, you can kind of see them, right?
Yeah, well, no, actually, the superficial venous system are those veins that are still deep to the skin. You don't typically you don't see.
Okay.
The superficial venous system. Now, varicose veins and spider veins and all that sort of stuff.
Those you can see.
Those you can see, and those are part of the superficial venous system. Varicose veins typically are branches off of the superficial veins. We call that the saphenous system. That's just the name of those veins. Mm-hmm. And those are the veins. Those veins are of note because of the fact that most venous insufficiency affects the superficial venous system. Those are the veins that we work on most of the time, day in and day out. At least in treating people with varicose veins and other symptoms of superficial venous insufficiency. But there's also the deep venous system, and we call it the deep venous system just because it's
way in there.
Yeah, the veins are deeper. They're a little bigger than the superficial venous system veins. They carry about 75-80% of blood flow out of our leg, as opposed to the superficial system, which is more like 20 or 25%. So those are the bigger veins. Now, one of the bad things that can happen inside veins in our legs is for blood to stagnate. Or for a number of different reasons, clot. The blood becomes clotted, and again that happens because of a variety of different things. But as you can imagine, blood clotting in a big vein, it may cause problems. So it depends a little bit on where it is. The further down the leg you go, the smaller the highway. The upper part of the leg is like a
freeway in comparison,
H1.
right? Yeah.
And
dirt road down the bottom.
down the bottom.
Cobblestone highway.
Exactly. So, blood clots that occur down around the ankle and lower calf are not as symptomatic, and there are nowhere near the repercussions. But, blood clots higher in the leg can be problematic for sure. And we'll talk about some of those problems here in a bit. But, the first question, we have, are blood clots good or bad? And they can be both.
I could say you need some. Right?
Yes, exactly. So,
stop bleeding, maybe.
Right.
Yeah.
Blood clots. And most of the time, blood clots for a good reason is kind of a very infrequent, although it's a common problem, but it's an infrequent occurrence overall when blood clots inappropriately. But if we didn't have a blood clot mechanism,
you just keep bleeding.
If you nick yourself shaving, you would just continue to bleed.
Yeah,
and obviously, as you might imagine, if you had a bigger injury of one sort or another, it would be pretty easy to bleed to death.
Yeah.
If we didn't have that intrinsic clotting mechanism. So why does blood clot? Well, like we said, it clots to protect us from bleeding, and most of the time when blood clots, it's a very useful thing. The other question is, if there's a system within our blood that creates a clot. And so what would the other kind of side, the other side of the coin is, well, if blood starts to clot, let's say you cut yourself shaving, in that the blood's going to clot locally, just like right there to stop the bleeding.
I hate that. You have to use that little pen or that little piece of paper or whatever it is. Dang thing never seems to stop bleeding, does it?
Right. Yeah. So, so what stops the blood from that clot propagating from whatever point that we've injured ourselves back throughout our entire vascular system? Well, that could happen, based on the mechanisms that we have inside our bloodstream that create blood clotting. However, there are systems that protect us against that. There are, proteins and chemical reactions that prevent us from overclotting.
Okay.
So, so the clotting system is made up of proteins and cells and whatnot that bring about a blood clot, but that same system, or the same a separate system that's very closely intertwined, prevents our body from overclotting. And if we didn't have that, then every time we cut ourselves, our entire vascular system would clot out. So how does blood clot? Well, blood clots, initially, the first step is that there are little blood cells that we have in our bloodstream called platelets. And I think, many people have heard of platelets.
Incidentally, I think this is great because I know right now, and it's always, there's a big demand at the blood bank for blood. And they tell you that blood can save 3 lives. Because of the different things that are in it. And, of course, you deal with those every day, one of them being platelets.
Right.
Yeah.
Yeah, so, when you give blood, when you donate blood, they take that blood and then they separate out the components. Yeah. The 3 main ones are red blood cells. Those are the blood cells that carry oxygen. The other one is plasma. And then the third component in the plasma is, what contains all of those proteins that, allow for the clotting system to work. And then the third category is this thing called platelets. And, platelets are probably the, most...
They're the big high demand one, isn't they?
Yeah, right. They're high demand. And so we try to limit transfusion of platelets unless we absolutely have to. So platelets are important because they have a role to play in the clotting process. What happens is that when the body senses that there is an injury, there's a cut, when we cut our skin or wherever, we're cutting blood vessels. We're cutting very tiny blood vessels, but nonetheless, they are blood vessels. And the blood flowing through those blood vessels have all those components in it, red blood cells, and plasma, and platelets. And the first thing to happen is that the platelets react. And it's all, through chemical messenger kind of things. The clotting system actually is a very, very amazing system. We're learning more and more about it all the time. The clotting system that I learned when I was in medical school, what we know today is much different.
Much improved, much different.
But, so the first thing that happens is that platelets aggregate, they stick to each other, and they form what is called a platelet plug. So, that's the very first thing that happens. Now, after that, then thereafter, again, through other, chemical reactions and, enzyme, mechanisms and proteins and all this sort of stuff, the actual thrombus then is formed, and that's in addition to a platelet plug. If you look at platelets, aggregated platelets, they have kind of a whitish appearance, as everybody knows from cutting themselves.
Yeah,
shaving.
from cutting yourself, you bet.
When you form a blood clot, obviously it's a dark. It has a dark bloodish kind of appearance to it, and that is thrombus that's formed because of all those other proteins that are interacting with each other. But again, the platelets very, very important. They kind of initiate the whole process. They bring about some hemostasis just by virtue of them aggregating, and then the clotting mechanism happens thereafter in a automatic sort of fashion. I mean, it is a very, very interesting, complex and very interesting kind of mechanism that we have, circulating in our bloodstream all the time. When there are things called, those proteins that we have in our bloodstream that lead to clot formation are called, clotting factors. And typically we number them, 1 through 12 or 13, and each one has a little different mechanism. But either bleeding problems, for instance, hemophilia. Hemophilia is when you lack factor VIII. So that's so if a deficiency in a factor can create bleeding issues. A deficiency in something else might cause clotting, problems, and so we'll talk about that also a little bit more later. But again, it's a very interesting and complicated system. There was an old German or Austrian, one of the two, physician. His name was Virchow. And
Virchow's triad.
Yes. Yeah. Virchow's triad.
See, I know little bits of this stuff, just little tiny bits.
So, Virchow, I think he was a pathologist, but he looked at this process of clotting, especially as it pertains to abnormal clotting. And he came up with this concept, and they call it Virchow's triad because there's 3 different things. So one of them is stasis. And we know about stasis because of the fact that that's what happens when we're on long airplane rides or long car rides, or or we're immobilized for whatever reason. If we get thrown in the hospital for one reason or another, blood is not, especially in the veins in our legs, the blood is not circulating the way that it should. It's certainly not circulating the way it normally does when we're up and around and active, and our muscles are contracting, and we're running around all day. Anyway, when the blood becomes static, it becomes more what we call thrombogenic, which means that it's more likely to clot. Virchow was one of the original people that came up with that idea. So
interestingly enough, though, and gang, you got to visit veinclinicsofhawaii.com to see some of this stuff expanded. But interesting what you say about that, because this whole thing about clots, some people are pretty well appraised of it, and some people are not. They just have no idea why that is. And so the deeper the cut, the more it bleeds, the more you're going to have a clotting problem unless you have something to happen with it.
Right.
Okay.
But yeah, you're right. We've got a bunch of information on all this stuff on our website. I would encourage people to go and check it out. But so the second part of Virchow's triad is intimal injury. Now, intimum refers to the inner lining of a blood vessel. So when we cut ourselves, we're cutting through blood vessels. Again, even if they're tiny little.
Some are teeny ones, some are bigger ones.
Yeah.
Right? Yeah.
And when that inner lining of that blood vessel becomes damaged, then that in and of itself is setting or putting forward, these chemical reactions that lead to platelet aggregation and also the initiation of the clotting system. So intimal injury was a second thing that he came up with that has to do with blood clotting, be it normal or abnormal. And then the third thing is hypercoagulability. Now, what do we mean by that?
Oh, that's a big one. I'm glad I didn't have to say that. Hypercoagulability. Okay, I got it. Yeah.
That just means that for whatever reason, our blood might be coagulating easier than it should otherwise. And, there's a number of different reasons why, our blood might be coagulating a little easier than it should in a normal situation, ranging from, medications that we're taking or, people that have cancer are hypercoagulable. Women when they're pregnant are hypercoagulable. There's a variety of genetic, things that might happen that predetermine us to be hypercoagulable. So, it's not like all three of these things have to be present to create, an abnormal blood clot. For instance, somebody might be perfectly healthy otherwise, but if they're on an 8-hour plane ride and they don't get up and walk and they're not maintaining good hydration,
perfect storm,
then the blood in the lower leg might become static and blood clot forms. Now,
what are some of the things that would contribute to a blood clot between normal and sick people or people that have conditions? You mentioned earlier cancer. Or being pregnant. Aren't there an awful lot of things that make a clot more likely?
Yeah, exactly. Sure. And most of them are, biochemical kind of things that are happening. For instance, when a woman is pregnant, there are hormonal things going on in their body, and the physiology of pregnancy makes them able to clot a little easier. Now, I think probably from an evolutionary standpoint, if you want to look at it that way, it has to do with the fact that, when pregnancy and delivery occurs, you want to have a fairly brisk coagulation kind of system.
I would think,
because of the placental separation from the uterus and all this sort of stuff going on. So, there are things. Again, there are physiologic and chemical reasons why that happens, and so that's what's happening. For instance, when somebody has cancer. Again, I think it's just biochemical and physiologic kind of things that are happening and being produced in that patient that make them more hypercoagulable. If somebody has heart disease, That probably has more to do with stasis, of the blood. If they have swelling and the blood return is not very good and all that sort of stuff. So it depends on what the disease process is. I think there's probably a myriad of different reasons, but we just know that, of course, in various disease settings, people are going to be more coagulable and therefore more at risk to dedeveloping a
so
DVT.
there's a short list of bad things.
Yeah.
Or actually, it's not that short. It's pretty long.
No, it's not that short. Yeah. So again, cancer, pregnancy, post-pregnancy. The other thing is that women remain hypercoagulable for 4 to 6 weeks
after they give birth.
After they deliver.
Wow,
yeah. So so that goes on for a while. Obesity. It makes you more likely to develop a DVT. Immobilization, like we've talked about. Hospitalization, again, that kind of goes along with immobilization and other disease processes. Traumatic injury, heart disease, lung disease, smoking, birth control pills. All of these things, put people at a little higher risk of developing deep venous thrombosis.
Somebody learned something and repeated to me when I ran into him in the grocery store about our show, and that was, a lot of people don't understand that there's not an unlimited supply of blood. You have a finite amount of blood in your body at any one time. So the deeper the cup, the faster you bleed out, right? So what we're doing here is these are different things that I guess you don't want a clot, because if you have a bad clot and something else happens, you are in trouble.
Yeah, for sure, absolutely. So we mentioned genetics, these are inherited kind of defects in our genetic code that may make people more susceptible to deep venous thrombosis. And this is something that people can and should be aware of, if they have a family history of deep venous thrombosis. If somebody is thinking about if somebody's listening right now and they're thinking, gee, my mom, I can remember, she had a couple of blood clots. It's not. One deep venous thrombosis means something, but if you have 2 or 3, that means something a lot more important, and that is that, gee, that person might be hypercoagulable. There might be something going on there that makes them more susceptible to developing a DVT. And if you have a family member like that, especially if it's a parent, then you should be going, gee, maybe that's something I should be concerned about. Or if you have, if your mother and an aunt, if you have multiple family members that have had, blood clots throughout the course of their life, then you should be thinking about that, and you can be tested. I
was going to say I've got a question for that, and that is, obviously you can do some testing and find out, but I would also imagine that this is a great time when, in this age of specialization that we're in, we go to the specialist for this, specialist for that. Pretty good to have somebody saying, okay, let's see all the medicine you're taking. Because maybe some of these conditions, by taking that other medicine for that other condition, you're making that one worse.
Yeah, and absolutely, and of course we ask what medications they're on, from day one, and typically that almost every doctor's office is going to ask that, I think most physicians are taking a look at drug profiles and seeing how it may or may not impact what they're treating that patient for. So we look at that all the time, but. We call that those genetic things that may make people hypercoagulable. We call those inherited thrombophilias, and again, that's just a fancy name for a genetic problem that makes people's blood clot quicker than it should. And probably the most common one is called factor V Leiden mutation. Like I mentioned before, we have these factors, these clotting factors in our blood, and this one particular inherited problem has to do with the fact that there's a mutation of factor V that makes it more active. So if a clotting factor becomes more active for one reason or another, then that person is going to be hypercoagulable. As most people know, we get a gene from our mother, a gene from our father, and most of these are related, or the concern for most of these inherited thrombophilias has to do with, do you have one or do you have both genes that are coding for that abnormal factor V protein. I believe we call that heterozygous or homozygous. That just means, do you have one or two genes connected with that? And
you're unlucky. I mean, who knew, right?
Right. Yeah. And in the risk, skyrockets. I mean, when you have both genes that are positive for something that like factor V Leiden mutation, then your risk of developing a DVT goes way, way up. I think the last time I looked at this, I believe it can be as much as 20 or 25% of people may have one gene for factor V Leiden mutation. Again, this is the most common one that we see. And so that's a fair number of people out there. And if you have just one, are you at slightly increased risk of developing DVT? Yeah, you are.
One would say yeah.
We typically don't get overly concerned about that, and it's not like we're going to put people on long-term anticoagulation for just that. However, if someone has both genes that are coding for that abnormal factor, then most of the time we're going to anticoagulate those people, because they're the likelihood of them developing multiple blood clots in the future is very, very high. So, and there are a number of other factor-related inherited thrombophilias which make people more likely to clot. Now, the other thing is, you might have that side of it. You may have things that are enhancing the clotting mechanism. However, on the other side of it, you may have a deficiency of those mechanisms that are controlling the clotting.
Yeah, so it's a two-edged sword. I mean, you got to differentiate where's this problem coming from.
Yeah, right? So it's a balance. For instance, there's something called antithrombo-3, and that's a factor that, or it's a protein that has to do with limiting clotting. And if you have a deficiency of that protein that's limiting clotting, it will make you your blood more clottable. There's something called protein S and protein C. These are all different types of proteins that are circulating around in our body all the time, and those are also intrinsic natural anticoagulants. If you are deficient in those proteins, then your blood is going to be more coagulable, and you're going to be more likely to have a DVT. So I think the point there is people can and should know about those things. And if you have a strong family history of DVT, it will benefit you tremendously to know your own status. And again, we can do a blood panel and figure out what people may or may not have with respect to that.
What I was thinking a minute ago is that probably today, with the diagnostics and all of the tests that you can do, it's I don't want to say it's easier, but it's more manageable for a physician to be able to figure out what's going on, because I would think a lot of people would just die from this. When they didn't see it coming and there was no signs.
Yeah, and we've talked about when do we need to be concerned about blood clot formation, and are there situations where you may want to limit your activity, or not do something, because of the risk. And we've talked a lot about plane rides and
travel,
or
long travel.
Yeah, travel. Yeah. Is there a time when you might actually suggest to a person that they not travel because of their risk of DVT? There probably are times like that. If somebody has multiple medical problems, especially if they're acutely ongoing, and that they have an inherited thrombophilia, and you want to correct their heart failure or improve their pulmonary function or whatever before they go on a long trip, you could certainly make that case.
Yeah. By the way, folks, some of these things that we're talking about are not leisurely or vacation. They're need to trips. There's some people that, maybe have to go and settle a family business or doing something. They have no option but to go on a long plane flight. So
Sure.
The more they know about their risk factor, the better.
Yeah, right. So we mentioned medications that may lead to DVT or make people more susceptible, and that birth control pills are one of them. I think most women at least have heard of that concept, that some birth control pills are going to make them more susceptible to DVT. And so does that preclude the use of birth control pills? Well, no. However, it does kind of move you in the direction of recommending one over the other.
Yeah.
Or other forms of birth control, in a young woman who maybe she does know that, or maybe she has a strong family history of DVT, and maybe she finds out that she's got an inherited problem that makes her more susceptible to deep venous thrombosis. Well, then maybe she isn't going to want to be placed on birth control pills, and there are other things that obviously can be done. So those are the kind of real life situations where you need that knowledge so that it will benefit you in deciding how you want to treat yourself. But birth control pills are probably the most common one. But things like tamoxifen, tamoxifen is the medication that many women get put on because of breast cancer after being treated for breast cancer.
Tamoxifen.
Tamoxifen. Yeah. So there's a lot of women on that medication, and that's a little higher risk for DVT. And again, does that mean you shouldn't take it? No, because it's if it's benefiting you in one kind of category, then you just have to be aware of the risk and make sure that your risk isn't too high. Make sure you don't have other risk factors that may put you over kind of the limit of your risk. So what are the So we know what a DVT is. I mean, that's blood clot that forms typically in the legs. Although we can have deep venous thrombosis in our upper extremities too. And usually they don't. Usually the blood clots that occur in the arms or in the large veins that are up in the upper chest and neck, usually those don't have the negative repercussions. Anyway.
We haven't started talking about that, gang, so pay attention because they're coming up, the repercussions.
Yeah. So, because one of the things that happens to blood clots in our legs is that they break loose. And they can travel, through the venous system upward through the heart, and then ultimately go out into the lungs. We call that pulmonary embolism. And pulmonary embolism is a dangerous thing. It can be very fatal. So that's one of the major things that we're concerned about. That's probably the most serious. Acutely concerning. When we diagnose somebody with a DVT, the immediate thing that we're concerned about is not only the long-term effects that blood clot will have on the leg, but we're also concerned about the fact that, there's a blood clot there. It might break loose. If it breaks loose, it travels through the bloodstream and through the heart And usually it just goes through the heart. It doesn't. It doesn't affect the heart, but goes through the heart and then gets pumped into the pulmonary circulation, and we call that a pulmonary embolism.
And now you got a problem.
Yeah. Well, now you potentially have a huge problem. Yeah. Because people die instantly from pulmonary embolism.
You may remember several programs ago when we were talking about this. A friend of mine's brother traveled in good shape. He traveled from Hawaii to New York, and he died. I mean, he had a DVT that he was in the hospital, and in the hotel room, and it was in massive pain and problems, and they just couldn't get to him in time.
That's kind of that's the typical story. Somebody's on a long plane ride and the blood clot in the leg happens while they're on the plane, and then they leave the plane, leave the airport, they're going on to wherever it is they're going on, and within hours or a couple days, that blood clot dislodges and boom, the patient can be instantaneously fatal. So
how fatal? That's what I was waiting for. This is the time in the program, folks. I want to reintroduce Dr. Randall Juleff. He's the medical director of Vein Clinics of Hawaii, and we talk about these DVTs, and you see them on TV late night. And this particular section fascinates me because it deals with numbers. Yeah.
Before we talk about numbers, the other negative repercussion is something that we call post-phlebitic syndrome. That has to do with the leg. The blood clot. Unfortunately, although sometimes it does, sometimes. We find a blood clot in the leg and we treat it. Basically, we treat it with blood thinners, in the clot. The blood thinners don't dissolve the clot.
Yeah, a lot of people think they do, but they don't really do that.
Yeah, they don't do that.
What do they do?
Basically, we start people on blood thinners just because we don't want the clot to propagate. So it stops the propagation, and it allows the clot to sort of become stable and stationary within whatever blood vessel it's in.
Wherever it's in.
And then over time, the body will break down the blood clot. But sometimes that happens. It's surprising. Sometimes people come in with a pretty substantial blood clot. We put them on a blood thinner, and then several months later, doing sequential ultrasounds to just kind of keep track of things.
Keep an eye on. Yeah.
With time, actually, in some people, not everybody, but in some people, the body breaks down the clot, and we don't really see much in the line of negative repercussion, from that blood clot. Now, on the other hand, however, in other people, they're not so lucky, and the blood clot in a large vein in the leg does have negative mechanical repercussions, and we've talked a lot about one-way valves. And the one-way valves that are in veins that keep the blood moving in the right direction, which are so important to the normally functioning vein. Those valves can be damaged, irreparably from the blood clot, because the blood clot, rather than dissolving completely, it kind of becomes very fibrotic, and some residual of that clot, stays attached to the wall of the vein, and invariably
just opens it up so the vein's not the valve's not working anymore.
Yeah, valve's not working, and so that vein becomes incompetent. Now, and we're talking about a deep vein, over a long period of time, that incompetent deep vein can lead to something that we call post-phlebitic syndrome, which basically just means the syndrome of things that happen to the leg over a long period of time if that deep vein isn't functioning normally. And basically what happens is, chronic swelling, and over time the skin of the lower leg becomes abnormal, thickened and fibrotic, and it can ultimately lead to chronic ulceration and skin breakdown, the way that we've talked about before. But that's all part of the what we call post-phlebitic syndrome, which strictly is just those negative repercussions that can happen to the leg from the DVT, after it has happened, and that's that happens over a long period of time, over years. But so anyway, how fatal is DVT?
This is where the shock factor sets in, because I got shocked when I saw this material. This is amazing, gang. Listen, and Dr. Randall Juleff is the medical director at Vein Clinics of Hawaii, and just by listening to this, you might want to think about making an appointment, because there's some really, really interesting facts about how fatal these things are.
Yeah. And we probably don't really know the exact numbers, because so many people die.
For whatever. You never know what got them. Right?
Yeah, if we don't do an autopsy, which a lot of people die without autopsies. We may not know exactly what happened, but more people die in this country each year from DVT, and I would say DVT/PE, pulmonary embolism, and its complications, than they do from motor vehicle accidents, breast cancer, and AIDS combined.
No, so, that was a showstopper when I read that. Because that's a lot of people. That's a lot of death.
Yeah. So, roughly 1 million people in the U.S. on a yearly basis is affected by DVT/PE. So of those 1 million people, somewhere up to 100, again, we don't know the numbers, but, probably 100,000 people are dying from typically pulmonary embolism is how they're dying. So, so it's an important problem. And,
that's a wake-up call to me.
we talk a lot about DVT here on the show, and I think, we do because it's warranted, people need to know about it. And people need to know their risk. What is the risk? So a couple of other things. If a person is untreated, then one in 10 people will develop a PE. So if somebody has
pulmonary
has a DVT, and they don't know about it, and they don't get treated, they don't get placed on a blood thinner, then 10% of those people will develop a pulmonary embolism. And again, we've already heard that pulmonary embolism can be, tremendously fatal. Pulmonary embolism is the leading cause of death in women during pregnancy and immediately after delivery. So, and again, we talked about women during pregnancy being hypercoagulable. So, PE is the leading cause of death in that situation. 1/3 of patients who have a PE and are who ultimately are found to have a PE, however, they were untreated and had a PE, do not survive. So the fatality of an untreated pulmonary embolism is about 33%.
Wow!
So that's pretty heavy.
Yeah, it's high.
Okay, so what are the symptoms of DVT? Well, basically, pain and swelling are the main ones. And although some are asymptomatic, and I'm always amazed because periodically we'll have a patient come in, and and they come in for, just run-of-the-mill kind of leg complaints that we typically see with venous insufficiency. And we do our ultrasound, which we do on nearly everybody, and we see evidence that they had a DVT at some point in the past, and they didn't know about it. This
is by ultrasound, and I'll share it because many of you know not only do I host the show, Dr. Juleff, but I'm a patient, and we've been keeping an eye on one of these blood clots in my leg for a while, and it's very interesting because over the last year or two that we've been looking at it, it's not changed radically. So it didn't indicate it's something that you say, okay, ultrasound just said, Mike, we'll just keep an eye on that. We'll watch it.
Yeah.
It's not nothing has to be done to it right now.
Right.
Yeah.
Which is a good point. I mean, there's a whole spectrum of of DVT, where they're located, and I was getting at that a little bit before. The further down the leg, the more isolated it is, the smaller it is, all that sort of thing. Every DVT is not created equal, for sure. The bigger it is, the higher up the leg it is, it becomes much more dangerous. So we especially in people who we are treating for other things periodically, a DVT may occur, but typically it's small. And it's isolated, and often we don't have to treat it like we did in you, not treating it and just following it.
Fine with me.
So, no
problem.
Sure.
Yeah.
So the typical symptoms are pain and swelling. Usually, it happens fairly suddenly, and it can wax and wane. It can go away. It can get worse, and that's why. It can be a little confusing for people as to whether they feel like they should, come in and see us or not. Yeah. If somebody's on a plane, for instance, for a long time, they get off and they've got a little bit of, crampy kind of pain in their calf. And they may write it off as just, sitting, having to sit in an airplane.
I think a lot of people do. That's a big error some people
for sure.
Yeah.
So pain and swelling, however, are the main ones. And, if you're in a situation where you might be at a risk of developing a blood clot and you have those symptoms, just be aware of it and, see your doctor, come in and see us or whatever. So, because it's a pretty easy way that we are able to diagnose DVT. And how is that? That's with ultrasound.
Okay, and a blatant proposal is come and see it. Come check it out, veinclinicsofhawaii.com, 4 Islands. We'll take care of you. Don't worry.
Yeah. The ultrasound, very quick, non-invasive, and, literally within 5 minutes we can tell whether somebody has a blood clot or not. And then, do whatever's appropriate. And how do we treat a DVT? Well, basically, it's with blood thinners. Again, like we said, blood thinners don't dissolve the clot. They just stop it from propagating and getting bigger, and, they help stabilize it, make it less likely, obviously, from the numbers that we looked at before. If we treat it, then it is much less likely to break loose and, follow the bloodstream, go to the lungs, develop a pulmonary embolism, et So, and then the other way that we can treat a blood clot in some situations is with a medication that does dissolve the clot. So there are medications out there that can do that. They're called thrombolytics. They break down thrombus basically. Yep. But it's not used for most run-of-the-mill DVT. We don't go through that. A lot depends on the medical status of the patient. Most of it depends on where the blood clot is.
I was going to say, if it gets it in harm's way, it might be a time.
Yeah. And again, like I mentioned before, the further up the leg the blood clot is, then the more the worse the overall prognosis will be.
But by the way, Doc, people need to know this. When you take a look at a blood clot on your finger or your toe, these blood clots that are in your legs can be pretty long.
Oh yeah,
I mean like many inches.
Right.
Yeah.
Yeah, they can
many feet.
They can be many inches.
Yeah.
And probably the main thing there is where is the vein and how big is the vein that's being obstructed. And that getting back to the thrombolytic therapy, who are the people that we're going to get that aggressive with? Because thrombolytics basically it requires being put in the hospital. You're in the intensive care unit. We put a catheter into the clot itself, and we're infusing medications into the clot that's going to cause that clot to
It's
dissolve.
pretty serious, in other words.
Yeah, it's a big deal. Yeah. And there's some risk to that. You know, there are bleeding risks, and so we don't usually recommend that older people and people with other medical problems do have that, but so the risks can be substantial. So it's not done in everybody, but the people that it is done in are those people that are healthy, can tolerate the medication, and have a very high clot. So if we do the ultrasound and if we do the studies and we see that the blood clot is located in the upper leg, and especially if it extends into the pelvis. Where we're talking large
and larger, and
large volume kind of blood vessels, then it's going to probably become more important for that patient to for us to limit the amount of clot that is going to remain there.
Sure.
So those are the people that are going to have those kind of procedures performed. So there's medications that can be infused into the clot to get rid of it. There are devices that we can use that actually break up the clot and can suck the clot out of the vein. There's a number of different high tech kind of things that can be used, which are all very interesting. But again, that kind of thing is not used on everybody. So again, the blood clot, the negative repercussion that happens to the leg is it disrupts the normal valvular function of that vein, and that leads to negative repercussions in the future. So one of the other thing I guess worth mentioning is that when people do come in and they have a DVT, it's best to get them into compression stockings. That we hear all the time that, or occasionally, I will hear people developing a DVT, and they either go to an emergency room or wherever, and they get placed on a blood thinner, and kind of get sent on their way, and being placed in a compression stocking is important to help flow, blood flow in that area. You want to maximize, continued movement of blood in the area of the blood clot, and
there's a reason for me to wear these things every day.
Yeah.
Big L.
And so it can be beneficial. So again, that's part of the treatment, compression stocking. So what can we do to kind of protect ourselves? And I think again, be aware of your risk, and find out the family history. I mean, that's important and pretty easy, although, sometimes it's hard to know exactly what, grandparents and great-grandparents, what happened to them. But, investigate family and find out, especially if you know that somebody had a blood clot, kind of ask around and see if there is more than just that one person that had a blood clot in your family. Ask your doctor, are you on medications that can make you more susceptible to DVT, and if you are on those kind of medications, what should you be doing to?
Yeah, let me ask you that. If you are, and yet you're going on a trip, would it be appropriate to maybe stop taking that medicine for a week or a couple of days?
That would
depend on what the medicine was.
Yeah, depending on the medicine, and totally up. That would be a discussion for, that person and their physician
and their doc. Sure.
And then no situational risks. Know that when you're getting on a plane, and if it's a long plane ride, which invariably it is, if you're leaving the state of Hawaii, know that you're getting into that sort of situation, and take precautions. I recommend. Just about to everybody that they wear compression stockings when they get on a long plane ride. It's never going to hurt you.
Yeah, and I have seen just a proliferation of these. I mean, I get mine at Vein Clinics of Hawaii, but they're online. And there's a lot of places, and of course, getting fitted with the right one and the right compression is important.
Yeah.
So that's and learning how to put them on and take them off. I mean, because it'll really discourage people if they have a struggle, if they can figure out a different way to do it. I've got the way. For a slight fee, I'll come to your house with you. I'm kidding.
There you go.
But anyway, thanks, Doc, and thank you all for listening to the program. And if you want to know more, it's easy. Go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. I hope that you've learned a little something about these DVTs today, because you see them on TV at night a lot. They advertise them a lot, and that's good, because that points out those that are susceptible and not. Once again, it's a genetic thing, I should say. So you want to work on that. Anything else you need help with? Don't be afraid to go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Tell your friends. We'll see you again next week. Thank you very much for listening. Aloha.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir. I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.